just a couple of defining terms here for this session that we're going to talk about when we get into some specifics, but I want to define the terms first. Preferred language and demographics. As we talk about demographics, we'll mention preferred language, and that's defined as the language by which the patient refers to communicate. And then also another important definition is unique patient. Many times for the meaningful use objectives, the denominator by which a percentage is based, the denominator is often defined as unique patients seen during a certain reporting period. So if we saw a patient 100 times during a 90-day or 365-day incentive reporting period, that's only one unique patient. So for many of these objectives and the measurements, we're really going to be talking about that unique patient, not necessarily every one of these encounters. Some of these requirements, such as vital signs, do not have to be actually documented every time there is a patient encounter. All that we'll show and talk about that really must be done is that sometime during the reportable period, there is information in the patient's EHR, their clinical record, that shows that vital signs are present. They don't have to be done at every patient encounter. With that being said, let's just take a look at these 4 different meaningful use objectives. One of the core objectives is the ability to record demographics, and that is defined as the data fields of preferred language, gender, race, ethnicity, and date of birth. I've worked with EHR vendors for the last 5 years and frequently helped them design demographic screens. The majority didn't have a field for preferred language or ethnicity, but because of the final rules and the Office of National Coordinator and the HIT committees that met as to what should be in demographics, this is the core that they came down to. So every certified EHR for demographics has these fields in there. And so the eligible provider, when demographics are recorded, these are the fields that should be recorded. The measure is that more than 50% of all unique patients seen by the eligible provider have demographics recorded as structured data. This is not an excludable objective. Talking the details a little bit about how this will be attested to in 2011, if this is the year that you'll be going for the be your initial year to apply for the incentives. The denominator is, again, we're talking unique patients, number of unique patients seen by the eligible provider during the EHR reporting period. Quite possibly for some providers who see a lot of Medicare patients for 2011 or whatever their first year in the program, that reporting period could be 90 days. So for a particular provider, a particular reporting period, it's going to be 90 days or subsequent years, 365 years. The denominator would be the actual number of unique patients. The denominator would be those patients who have all the elements filled in their demographics during that period of time, recorded as structured data. And so that doesn't mean, as we mentioned, that every encounter this has to be updated or this has to be changed. But during that reportable period, denominator going to be unique patients, numerator, what percent of those unique patients, the number of those unique patients that have completely filled in demographics. Of course, always an interesting question is when this denominator and numerator are generated, where are those numbers going to come from? Some EHRs will generate these numbers automatically by queries to the database. Other EHRs leave it up to the provider to come up with these numbers. So a wide variety of how these numbers will actually be documented, where they're actually going to come from. something to pay close attention to. The resulting percentage must be more than 50% in order for this eligible provider to meet this measure. That doesn't seem like a very high requirement to me. All they're essentially saying is that if you have certified technology, if you want the EHR incentive, at least half your unique patients, or slightly more than half your unique patients, must have the demographics filled in for at least one of the visits during that reporting period. A little more additional information about demographics. The race and ethnicity codes should follow the current federal standards, which are published by the Office of Management and Budget. I've been involved in probably the last 6 months in 30 or 40 different EHR Stage 1 certifications. And to get demographics certified, these EHRs have to meet the same standards. So everyone I've seen already has these race and ethnicity codes embedded in their applications, usually a pull-down menu. If a patient, it's a question that comes up quite a bit, pretty fascinating, one of these what-if questions. If a patient declines to provide all or part of the demographic information, really not unusual, or for whatever reason, if caption ethnicity or race is prohibited by state law, it's okay just to note that, and that still would count as structured data, even if we don't are not able to actually document the true data. It would still count for us. It's not our fault. We couldn't gather that information. So there's all we have to do is just document that the patient declined to provide this information. And eligible providers are not required to communicate with the patient in his or her preferred language in order to meet the measure of this objective. I think that's pretty self-explanatory there. We just need to capture those data fields. The next meaningful use objective, as a core objective, is the ability to record vital signs, height, weight, and blood pressure. And the certification requirements around this is that a certified EHR can allow this input in English, metric, some combination of those, really any way they want to. And so the EHR you may use, the actual units may vary, or you may be able to put them in any kind of units you want. It doesn't really matter in the purposes of meaningful use and certification. But we have to be able to put in the height, the weight, and the blood pressure. The software, any certified vital sign EHR module automatically calculates and displays that body mass index. And then there is the third requirement, to plot and display the growth charts for children 2 to 20 years old. I've done a lot of work recently with EHR vendors who never had the need to plot and display growth charts, and will never have that need. But their EHRs do have to have this capability. These are gender-specific growth charts with percentile curves, normal percentile curves, and certainly no requirement that any eligible provider do this, because there are exclusions, but the certified software has to be able to display these growth charts if the data was in the record. The measure is that for more than 50% of all unique patients, there's that phrase again, 2 or over, that are seen by the eligible provider, height, weight, and blood pressure are recorded as structured data. And again, that period of time, if the reportable period, the second or third or fourth year of meaningful use is the entire year, and if this patient comes in 100 times, all that matters is that once during that reportable period for a unique patient to be counted, this information was in there one time. Exclusions are eligible providers who see no patient 2 years or older, or who believe that all 3 of the vital signs, height, weight, and blood pressure, have no relevance to their scope of practice. And quite a few specialists, this is outside the scope of their practice. So I imagine we'll see a lot of exclusions based on the recording of vital signs. Again, the denominator, number of unique patients aged 2 or over during the reporting period. I mentioned again, it's not practice by practice, but these measures are by eligible provider by eligible provider. The numerator is the number of those patients, the denominator, who have at least one entry. Doesn't matter how many encounters we had with them, at least one entry, height, weight, and blood pressure recorded as structured data in the EHR. And the exclusions, we've already discussed those. So the only requirement here is 50%. That seems very doable to me. And I'd be surprised if any eligible provider who did not exclude this objective would have difficulty meeting that 50%. A little more information. It is okay for the provider to limit the measure of vital sign objectives to those patients who are maintained using certified EHR technology. There is a requirement that for the incentives, at least half of a eligible provider's patients, greater than 50%, must be documented with certified EHR. So if there's another practice where the physician may be seeing a smaller number of patients, and that office or that location has not converted to a certified EHR, those patients over there that are just being documented on paper, they do not need to become part of the numerator or denominator. Only real information the provider or the provider staff needs to input will be the height, weight, and blood pressure, and the BMI and growth chart are automatically generated out of the certified EHR. And good to see that they really put in some, to me, thoughtfulness around the workflow of an office, and that height, weight, and blood pressure do not have to be, no requirement for it to be updated at every patient encounter. They're really leaving up to the eligible provider to make that make that determination based on the clinical encounter, what's going on with the patient, and the real need as to whether the vitals need to be documented and updated. Good thought here about how this information can get into the medical record as structured data. Usually what I see in EHR is somebody on the staff actually enters this. Usually not the eligible provider, could be somebody on the staff, which is just as fine. Height, weight, and blood pressure directly into the clinical encounter in the EHR. Transfer of information electronically. There are ways for it can be done from home, a patient, or at some type of kiosk environment where the patient's entering data that comes in automatically. There are some, I haven't seen any automatic height devices, but I've seen some blood pressure and weight devices that electronically interface with EHR, and the vital sign information can come in that way. So they've left the door open here for numerous ways of input. Next core objective is the recording of smoking status. The core objective is that we need to record smoking status for patients 13 years or older. The measure, very similar to the other ones we've seen, is only at 50%. And I would think that for most physicians where there's, or providers where this is within scope, that's not going to be a difficult target to meet for stage 1. The early indications for stage 2 come in 2013 at the earliest, and then 2015 for stage 3. These percentages are expected to rise. So the threshold to meet these and some of the workflows will definitely become more robust and more complex. But only 50% of all unique patients have to have smoking status recorded. They smoke, they don't smoke, they're a daily smoker, they used to smoke, they're thinking about smoking. The National Institute of Standards and Testing, which have come up with testing procedures for certified EHRs and for the certification requirements around recording smoking status, has broken it down to a minimum of 6 smoking statuses. Your EHR may well have more than those, but there are a minimum of 6 that may be in there. Exclusions: any eligible provider who sees no patients 13 years or older. How are we going to attest to these? Denominator: number of unique patients age 13 or older seen by that eligible provider during the reporting period. The numerator is the number of those patients who have something documented as a smoking status. This is one of the, to me, one of the few areas where it'll be very, very easy for the EHRs to come up with this number for a numerator and denominator. It should be relatively easy for the EHR to know that Dr. Jones, during a 90-day period, how many unique patients they saw, and then how many of those unique patients have some type of indication from structured data of their smoking status. Those two numbers allow that generation of that percentage. So this is one of the areas where I think it should be relatively easy to come up with the numbers. Again, the same language from CMS that we can limit this objective to only those patients whose records are maintained using a certified EHR, and we can, at least for stage 1, not worry about those patients who are being documented on paper. This is a check, as they say, also the medical record that's really for patients 13 years or older. Inquiry does not need to be made every time a provider sees a patient 13 years or older. And so if an 18-year-old comes in 12 times during the year, we're not having to look at every one of those encounters. We're just checking the age of that patient and seeing if there is a status in the smoking history area. And again, more leeway and welcome leeway. The frequency of updating this information is left up totally to the provider. And no attempt to tell the provider how to practice medicine or how to document or when to document these things. Next objective is one of the menu objectives, and of course that means that's one of the 10 menu objectives, 5 of which can be deferred. So just off the beginning, this is one that can be deferred for any reason whatsoever, at least for stage 1. Stage 2, all indications are there may be exclusions of stage 2, but the menu set, all are going to be required, not only 5 of the 10. The objective here is to incorporate clinical lab test results into the EHR as structured data. And what they mean by structured data is if we get a lab result as a fax or a piece of paper and we scan that into the EHR, that's not considered structured data. It cannot be searched. It cannot be put in a database, typically. It cannot be reported upon. And the measure here is that 40% of all clinical lab tests ordered by the eligible provider during the reporting period, whose results are either in positive, negative, or numerical format, biopsy reports, I imagine CNS reports, cultural sensitivity reports, those types, not including this, but it's really positive and negative or numerical format that they would be incorporated into the technology of structured data. Automatic exclusion could be granted for any eligible provider who orders no lab tests whose results are either positive, negative, or numeric format during the EHR reporting period. So if a provider doesn't order any of these type of tests, then that in itself is a exclusion very much off the top there. And again, one more time, just to reiterate and go into details, that denominator is that reporting period by a particular eligible provider, the number of lab tests that were ordered, which were based on a positive or negative or a number. And the numerator is the number of those which were incorporated as structured data. And we discussed the exclusions already. Either you don't order those kind of lab tests, and so you can't be expected to receive them back, or you don't exclude them, but since it's in the menu set, you could defer this, at least for till stage 2. And the only requirement is that 40% of your percentage here is required to meet this measure. Very similar that we can limit this objective only to those patients whose records we're keeping and maintaining in certified EHR. The structured data for the lab results. This is interesting. I was actually talking with someone about this very day. The structured data does not have to be electronically exchanged in order to qualify for the measure of this objective. So it's not only coming in through an interface, perhaps with a large lab entity, Quest or LabCorp, or some large outpatient lab at a hospital to a physician's office. It can come in other ways, such a way as manual input. If the lab results are delivered as a fax or paper in the mail, somebody could manually enter those into the EHR. That would be entered them as structured format. The option that they mentioned there of scanning or other means, I've looked for clarification on this, and I do not believe they're talking about just scanning in a piece of paper. I think what they may be really referring to is scanning into an optical character recognition type device, OCR, which could take that data and turn it into structured data into the EHR. At the last real comment there is that the incentive program does not specify the use of what code set standards are to meet the measure for this objective. LOINC, which is the kind of the universal cross-mapping for all laboratory codes, and so every lab in the country can point to a LOINC code and map their own individual lab reference numbers to a LOINC code, has made that a part of EHR technology. And so LOINC codes are tracked in the EHR technology, especially when certain types of interoperability files are output, but not necessary here where we're just incorporating the lab results into the patient's record. Thank you so much for listening to those. I just want to mention a couple of resources here. One thing I've noticed is that as time goes by, more and more questions continue to arise around, for about 6 months, is around certified technology. Now most of the uncertainty is around meaningful use. And as soon as 3 or 4 questions that seem to be drifted around are well understood and well clarified, then here come another wave of questions that we all need answering to. So as we move forward, I think it is important to continue to look for just for information, because there is no final word. This is a 5-year, 3-stage process. And the clarifications are going to be changing somewhat. The regulations are going to be modified. to me, one of the biggest issues around meaningful use, I've mentioned a couple of times already this evening, is the workflows associated with actually obtaining these numbers, these numerators and denominators. For some EHRs and some practices, that may be very, very simple. And I really encourage practice to start understanding and find out where and asking their EHR provider, if they already have an EHR, where these numbers are going to come from, and their suggestions and workflow requirements. Because unless we have these denominators and numerators and resultant percentages, we're not going to be able to apply, and certainly not going to be able to get any of the incentive money. Some resources I'd like to mention: the incentive roadmap. This is a manual I wrote for medical practices based on developing your own meaningful use strategy for stage 1, kind of a step-by-step process. Also, the virtual extension center I'm involved with, hightechanswers.net, totally free of any charges for hospitals and eligible providers. We get a lot of questions there on a daily basis. Ones that we don't know, we have pretty good access to CMS. We get answers from CMS. Anybody who's on this call right now is probably already a member of this virtual extension center, because that's why you are getting these, being attendees in these presentations. And then, of course, the mothership, the CMS website for their Medicaid and Medicare EHR incentive programs. Very good site, a lot of information there. Sometimes it takes a little digging to get down to the bottom of it. Okay, great. Carol, I'll turn it back over to you. See if there's some questions there.
We do have some questions. We definitely have some questions. Certainly, last night was a little different with as many objectives as you looked at, but tonight we've got a few. And some of this you've already touched upon, so it doesn't hurt to retouch back upon it. The first question is, which specialties are required to record vital signs?
That is a great question.
Yeah.
There's a CMS in their regulations has not put out a list that says who is required to do vital signs. But what they have said is that if you believe that it is outside the scope of your practice and you do not typically record vital signs, then you can attest to that, and that is fine. And there are many specialties I can think of, off the top of my head that probably don't do vital signs. Probably typically psychiatrists may not. Radiologists who may or may not be doing direct encounters with patients, chiropractors or eligible providers. I imagine that eye healthcare. I don't remember having my vitals done when I've gone to my eye doc. So
right.
It's really up to really up to the provider and the specialty to make that own decision.
So next question, if, nothing regarding vital signs, if we are excluded from capturing the vital signs, do we still need a place on our EHR to capture this information, even though it would be empty, in order to be certified?
Yep, great question. The requirement is that to be eligible for the incentives, we have to have complete EHR technology. And so that means that you have to have either a complete EHR by have, CMS defines it as have legal possession, whatever that means. A complete EHR, yeah, and the rest.
You can't steal your EHR and be certified.
No, some of them are free. They're free.
Proof of purchase required.
Yeah, exactly. Carrie, you made me lose my train of thought. Pick it back up for me.
Yeah, so this idea of like even if you don't, if the field is empty with vital signs because you didn't capture it, can you still certify?
Oh, right, exactly. Yep, there's no problem with that. And I think maybe the further question may be an example of if you don't e-prescribe at all, or you e-prescribe or you prescribe so little that you can exclude it, you still have to have certified e-prescribing software.
Right, right.
Yeah.
If an EP sees patients in a nursing home but records them in their EHR, will they count in the denominators for the meaningful use objectives?
Well, if they are using them for their, every time I've seen any clarification from CMS on this is yes. If it is their patient and they're seeing them with certified EHR technology, I presume they're carrying around a laptop or something.
Right, right.
Yeah, and document. Yes, that would count.
This question kind of came up in the middle. You were talking about the 50%. What will be the thresholds to meet in stage 2? I think they're looking at 80%, aren't they?
You know, I think we're going to see more in the interim final rule. Whenever that was last year, we saw some of those. We saw some of those higher percentages, 80% in some cases.
Yeah.
And then when the final rule, some of these roll back to 50%, and some of the meaningful use objectives were totally removed. The ability, I'm not sure why it was even in there, but the ability to do electronic billing for a patient, insurance reimbursement. I'm not sure why that was in there, but that was taken out, and they said that'll be back for stage 2. So I think we'll not only see higher percentage thresholds, we may see some more objectives, and I would imagine see more complexity to the objectives that are standing.
Right,
so.
Right. When you say a provider can be excluded from certain objectives, for an instance, vital signs for an optometrist, who decides when an objective is outside their scope or practice? They have to prove it somehow, right?
Well, they don't have to prove it, but what they do is they attest to it. That is the only requirement.
The provider, right? The provider attests to it, not someone else.
That is exactly right. And the exclusion is for vital signs. If the provider, I'm going to quote CMS here, believes that all 3 vital signs of height, weight, and blood pressure have no relevance to their scope of practice. So it's really a decision of the eligible provider. Then filling out the form, that online form, whenever that magically appears on the internet, when we all eligible providers can apply, we're going to select no next to the appropriate exclusion, and then click supposedly on a button that says apply in order to attest that exclusion. Right. So we're going to do it and then attest that this does not apply and has no relevance to the scope of practice.
Okay.
And I don't have a sense, and I'm doing quite a bit of work with some of the regional extension centers as well as with the ONC, and I don't have a sense that they're trying to do a punitive system where they're trying to catch anybody. I think they understand that a number of these things are outside scope of practice, and they're going to give everybody leeway. So
sure.
Yeah.
If we perform a clinical test, such as a biopsy, if we manually enter a positive or negative result, would that meet the requirement for clinical labs?
Well, the requirement said if it's just well, and so you perform it yourself and enter it, correct?
Yeah, right. That's what the attendee is
exactly
suggesting, right, right.
Yeah. Let's see. So entering that lab, enter a structured data, and it's going to be a positive and negative. So yes, it would. Sure. It would.
Yeah, right.
That's right.
Question.
But and let me say, because the denominator, there'd be 1 unit in the denominator where it was ordered. You would add 1 to the denominator, and then when you actually entered it as structured data, that would add 1 to the numerator.
There you go.
Yeah.
Right. Right.
Yeah.
This question actually came up last night, which is have the stage 2 proposed rules been released? They're talking about the end of the year, I believe, on that, right?
Everything I've heard is that end of the year, and public comment is being taken right now. And so they certainly have the committees and the process together. It was kind of grueling to watch them go through stage 1 because there was not a process to work through all these issues. But that process is now, and I think very easily they'll meet that by the end of this year. And it'll be very clear by this time next year what's going to be required for stage 2 in 2013.
Yeah. And I also think that the public comment, I think it was 45 days. I think that's through the middle of April. I think that they're taking public comments. Yeah, I think so. You can go on. You can go on the website, CMS website, and contribute to that if you want.
Okay. And they listen to that. They do listen.
Yeah,
to
sure,
that.
sure. I'm confused. You said initially the scanned or fax lab results do not count as structured data, but the next slide said the scanned lab results can be counted in the numerator. If you could please clarify, that would be great. Thank you.
Sure. To me, this is the area that I think what CMS is saying is a little bit confusing, and I'm not saying to have the final answer here, but we do have to, the lab results, lab data has to go into structured data, and scanning a piece of paper has lab numbers on it by itself is not going to be able to become part of structured data. Unless there's some way for that scanning to involve optical character recognition. So for that LDL of 125, when it gets scanned in, that actually 125 becomes data in the system that can be searched and reported upon. So the typical ways we think about scanning in an image, I don't think that's going to work. But if it can be scanned in a way in which the images are turned into data. Right. Right. And now, I haven't heard it discussed any more than we have discussed it tonight. But there are a number of requirements that are involved in meaningful use, certainly for certified technology, and then also for meaningful use to generate certain types of patient reports. And one example is patient reports have to be generated based on lab values. Like I want a list of all patients of the age of 15 who are on Lipitor who have an LDL over 110. And if those LDL lab values are not in their structured format, they wouldn't be part of that report. So I think traditional scanning won't work unless it's optical character recognition. Yeah. Again, I haven't heard the details yet from CMS, but I'm certainly looking for them. I don't think traditional scanning will work.
Just to go back and clarify too, somebody, Roberta chatted in that actually the comment period for stage 2, the deadline is, my bad, February 25th, not April 25th. So it is February 25th.
So the deadline is coming up.
Yeah, the deadline is definitely coming up.
Sure.
Somebody related back to the scanning issue, somebody chimed in that they think maybe they were referring to barcode scanning, which that's obviously data, but yeah.
Okay, yeah, that's right. It might possibly be.
Yeah.
That might possibly be. Sure.
And we've got time for one more question, I know, before you have to go.
Okay.
This is a great question. Is there a place on the web to go so we could see what a sample certification form would look like?
By certification to apply for the incentives, or
you know,
that person
could that person
sure.
ask that question, chat back in?
Yeah.
She did to enter data.
Mm-hmm. So that is probably going to be when the eligible provider is really ready to attest.
Right, that's correct.
That those means use. If you find that, let me know, because
I've not seen
and,
that at all.
And I don't think it's up there yet. The very earliest that anybody, of course, the registration process has been going on, but the earliest anybody's going to be able to apply will be in early April. because they would have 90 days if they were ready as
Yeah.
of March or early April. So they've got to get it up sometime before April 1st.
Yeah, that's a great
If you
question.
wait,
We'll be on
yeah.
the hunt for that one. That'll be great. Jim, I know you said you had to leave at 1:15, and I've extended your time by 5 minutes. So
well,
thank you,
so
everybody.
much.
If we didn't get to your question, we'll go ahead and send me the question. Email me if you'd like, and we will go ahead and try to put it in the FAQ. And again, stay tuned to what's happening in the VEC as we answer these questions. And finding a sample certification page for attestation would be terrific, and we will be on the hunt for that.
Sure.
We'll see you back tomorrow night at 7 o'clock for part 3. Thank you, everybody.
Thanks so much. Okay. Thank you.
Bye-bye.